Okay. Good afternoon. We're going to start our afternoon session with Dr. George Beran to talk about rabies elimination. Thank you.
Good afternoon. I would like to talk about rabies elimination as a James Steele model. And that's what it is. And it's a part of this whole picture that we've been involved in of One Health model. And rabies is certainly a very important one to begin with and to move on. As veterinary medicine and human medicine provide medical care to animals and humans, they have the potential to provide us a better world through One Health. An appropriate example is in rabies eradication. Canine and human rabies are still a reality in several countries in Asia and Africa, and that's where I will focus. And control programs successfully applied in the United States and in Europe and Japan and some Central and South American countries are simply not effective in the developing countries of Asia and Africa. It's been my experience to have spent a good share of my career in Asia, in the Philippines and other countries of Asia, and in Africa, predominantly in Nigeria. And government priorities, population density, and cultural practices all necessitate different approaches. I will illustrate. In the Philippines, where my family and I lived for many years and worked there, vaccination of dogs became a local government priority when there were 7 human deaths from rabies in people who had taken the local vaccine after having been bitten by rabid dogs. And an elected government official's son was bitten by a rabid dog, and we were able to get vaccine for that child, so that child survived, but not the 7 others. An understanding of cultural practices is really essential when we talk about One Health. In countries where systematic dog vaccination is in place, owners routinely vaccinate their pet dogs at their own expense. That's in the rich areas, and there are not so many of those. It would be if a would-be burglar thinks the dog that is guarding the property is a dog that could have rabies, may be transmitted, the robber is not likely to go to that hole. Hence, dog owners need to be convinced to vaccinate their dogs. So in planning a public health campaign, such as rabies vaccination, authorities knowledgeable about cultural practices need to be on the planning team. So as do medical doctors, government officials, laboratory personnel, veterinarians, and Dr. Steele. And that's the route that we have used. In the Philippines, I led a team successfully eradicating rabies. It was a complicated challenge necessitating careful utilization of professionals from several different disciplines. We knew it would not work to just announce, we're going to have a dog vaccination program. We utilized rural sociologists and schools with materials that the children took home for education of their parents, radio programming, government support, private and public medical personnel, and veterinarians and laboratory diagnosticians. This scheme was later successfully applied in several countries in Central and South America, as well as what we had done in the central part of the Philippines on an island that bordered on the Pacific Ocean. I will give some detail illustrating the role of the professionals involved in rabies elimination. The persons that have been discussed in the talks this afternoon in One Health, I'll put their names with them. This can also be effectively applied and adopted in control of other diseases. And so we have here with us today Dr. Babasola Olugasa from Nigeria, who led a program on this in Ibadan, Nigeria, and over in the University of the Philippines, Dr. Teodulo Topacio, and at Silliman University, one of the best known in the central part of the Philippines, the president, Dr. Malayang, and the person who works with the rabies program there on the island, Dr. Christopher Ablon, and myself, who's back from Philippines and here now. Educators were involved in designing the educational program, and those veterinarians helped greatly. Physicians examined residents who had been bitten. Physicians required those who had suffered bites to identify the location and owner of the biting dog. You'd be surprised how difficult it is to get them to identify the owner of the offending dog. Following examination, the medical doctors who had diagnosed and treated citizens in the clinic or hospital reported to the community health officials that they had done this. Medical care of the patients was assured, and post-exposure vaccination was promptly provided to protect from progression to human rabies. But what we so commonly heard about was the patients themselves. And the patients would be hospitalized in whatever clinics they could, and the positively confirmed human patients were provided possible relief, but that's all that you can do. Prior to the vaccination campaign, laboratory examination of dog brains by fluorescent antibodies for rabies infection was routinely conducted by laboratory technicians in the laboratory there at Silliman University that was initiated with Jim Steele's assistance, and that we moved forward. Physicians administered post-exposure human vaccine. Canine rabies vaccine was produced at the same laboratory there in the Philippines. We worked all the things out on that and developed the vaccine, which we licensed, and then we used it. And it was used to immunize approximately 250,000 dogs in the Philippines and in Mexico, South America, and in other parts of Asia. Rather than just announcing the vaccination program and the location of the clinic, rural sociologists advised that we would have to go door to door. And we would have to carry with us then the insulated boxes of vaccine and equipment, and we'd have to walk for miles, and we did it. All dogs were vaccinated, whether they were owned or roaming dogs. Those that could not be caught and held were eliminated. Rabies confirmation was conducted in any area of suspect dogs. Permanent control required vaccination every 2 years, and the system worked. And we thank you for the opportunity to share it.
Good afternoon. My name is Logan, and I'm from the College of Veterinary Medicine at Texas A&M. And today I wanted to talk a little bit about food security in developing nations, balancing the needs for animal health and public health. I moved back from Dakar to College Station, and 3 years ago I was working with AVES International Services and spent a 6-year period working in the Middle East and Africa. I've also worked in Africa and the Middle East off and on for about 20 years. I've served 2 agencies in the USDA. I've worked for the state of Texas, and now I'm serving as a department head and also director for international programs. I would like to congratulate Dr. Steele on his 100th birthday. He joined us recently in June in Hueston at the 63rd Annual James Steele Conference on Diseases in Nature, Transmissible to Man. It's a picture of Dr. Steele. He's always been a champion of the concept of One Health. And this particular conference that's been held in Texas for 63 years has been a wonderful opportunity for people in animal health and public health to come together and talk about zoonotic disease issues. Now, just a little story about one's individual perspective. And all of this comes depending on your experience and your work experiences and your life growing up experiences. A young faculty member texted me to say, "I've caught some fish." I sent him a text message back and said, "Where are you?" He says, "Reunion." Now my perspective was Reunion. Oh, the Isle of Reunion. He is there on a beach fishing. That's from my background. But he was at a family reunion. So he had caught some fish, probably in Uvalde, Texas. So it's all about your perspective. And that's the important point of teamwork, bringing different perspectives to the table. Now sometimes I feel like you can be in the forest, lost in the trees, and you don't see the big picture. And certainly we can all think of areas that we can improve and ways we can do better. And we've certainly had 3 wonderful days of discussions about One Health and about international global engagement. But I thought instead of talking about all the bad things that we could do better, let's talk about some of the things that we have done well. And when I say we, this is the big we in parentheses. Well, one of the things that I particularly would like to compliment us on is the fact that we've had 3 wonderful days at this forum, and these have been really good for people to communicate and develop new collaborations. We have had the monthly phone calls that are produced by Paula Cowan of the USDA Veterinary Services, which bring a broad group of people together interested in working in the Middle East and Africa. It started in 2004 when she was helping me put together a workshop with the military that we held in Kuwait. And that phone call has continued for the last 7 or 8 years, thanks to Paula, and we have a large number of people involved in those calls. So we appreciate Veterinary Services providing this. We've also done a good job using a platform of coordination for training programs, for capacity building and epi-surveillance in regional animal health centers in Africa, which brings together the African Union, the FAO, the OIE, and also the USDA and USAID have worked to help deliver these programs. We've done a good job of eradicating rinderpest, and we've done a fairly good job in preparing people to respond to high-path avian influenza. Also like to recognize the efforts of Mo Salmon and his teams in putting together short courses for transboundary diseases and epidemiology, and also Plum Island for providing the support. And based on my experience with the military, I think it's been a tremendous boost that the military has partnered with Corey Brown to prepare their troops for deployment around the world by giving them some cultural adaptations to help them do a better job and to help them understand how animal health works in other parts of the world. That has been great. So partnerships, networking, these are all essential for success. This is just a picture to show Paula Cowan helping me deliver a workshop, Middle East Peace Initiative funding, which led to a series of no less than probably a dozen workshops on the issue of trade between the Horn of Africa and the Gulf countries that are in the Arabian Peninsula. And Paula has been served as a facilitator on a number of workshops that I tried to host in partnership with other colleagues in Afghanistan, Iraq, Pakistan. She helped me specifically in Kuwait, in Iraq, Oman, and Yemen. Here you can see a workshop we held in northern Iraq, and Craig Carter is there with me, Paula Cowan, Mo Salmon, Prima, and also Max. Now, leaders in One Health, and particularly those with a global interest, often got an experience as students, an international experience, which influenced the outcome of their careers. And this is something that I think is so critical. I've listed a few colleagues there that I feel had an international experience as a veterinary student or earlier. And these are people you can see are providing a very valuable leadership role now in the world of global engagement and food security. Juan Lubroth, Tillahan Yilma, Peter Fernandez, Jeff Mariner, Luis Rodriguez, Mo Salmon, Corey Brown, Jerry Saliki, Peter Cowan, Saidu Timbeli, Tracy McCracken, Sherry Wainwright, Valerie Reagan, and Linda Logan. So we're all involved. Something grabbed our attention as students and put us into this arena to work on One Health and food security. Now you may think that this looks like a bunch of Texas vet students, but they're actually Italian vet students who spend the summer with us, and we have veterinary students who come from about 6 vet schools in Europe every summer and spend some time with us in the veterinary clinics, getting more of a clinical experience than they are able to because of all the regulations with students touching animals in Europe. As I mentioned, the regional animal health centers worked well. I didn't want to repeat all the good things that were said the last 3 days, so this is something to just show you a partnership of 3 or 4 agencies working together, and 4 regional animal health centers serve as platforms for training areas. The one I worked most with was in West Africa. It was located in Bamako, Mali, and I assume that means we're getting close. The lab capacity building was put on in Bamako, Mali, and we worked with countries in West Africa and Central Africa. And this program initially was started by the USDA-APHIS. Many collaborators, and so those are just some of the examples of areas that we've been successful in collaborations. Thank you.
Thank you, Dr. Logan.
Let's get ready.
Dr. John Clifford.
Thank you, Karen. Hi, Dr. Steele. It's good to see you, even if it's on video. And I wanted to tell you I really enjoyed the time to get to know briefly your granddaughter at the OIE meeting where your award was presented. So it's a great opportunity and pleasure to be here with you all. My talk is about One Health and public practice, basically past, present, and future, but it really focuses on APHIS veterinary services. But I think toward the end of this, I certainly want to use that as a way to build upon some of the comments earlier that were made by many of you, including Will and Lonnie and others, about facilitation roles and working together and defining roles, and I think also talking about developing new models of approaches to disease issues and to make sure that those approaches can be sustained. So what does Veterinary Services APHIS really bring to the table to assist in this area? 4 years ago, we were an organization of over 2,000 people US-wide. We have the Centers for Epidemiology, Centers for Veterinary Biologics, the National Veterinary Services Laboratories, as well as working with many of the state labs in the National Animal Health Laboratory Network. We do a lot of surveillance of livestock and poultry diseases, regulation of movement and animal products. We work internationally on those, as well as with our partners in APHIS from international services. We have people embedded in FAO. We have people embedded in OIE and other parts, Department of Defense and other organizations. We work very closely with our counterparts in FDA, CDC, FSIS, and many others. So we also bring emergency preparedness and response activities. We have an on-farm presence, and we have built trust and respect with the producers in the industry in this country, as well as provide expertise, infrastructure, as well as other networks. So where have we been? In the past, well, when you talk about APHIS in the past, you would always hear about brucellosis and TB. And the TB eradication program actually began in 1917. So Dr. Steele, Jim, the TB eradication program is not quite as old as you are. It's 4 years younger. But that's not a good thing. Not in this case. We've come a long way in the eradication of TB. In fact, in 1917, about 20% of the cases, human cases, were M. bovis. But you still can have M. bovis cases today. In fact, migrant workers is a big concern of ours with regards to the ability and possibility of transmission from human to cattle. Brucellosis eradication program began in 1934. We began many years ago with Will and Lonnie and many others involved in the NOMS program, the National Animal Monitoring Surveillance, where we've been collecting data since the 90s on antimicrobial use. We've collected data on E. coli, Salmonella, Campylobacter to help better inform decisions by others in these areas. 2004, we had our BSE response, and now today we're negligible risk. So many of those things are the past. In the present, we do a lot of surveillance activities in influenza that affect both the swine and human populations, as well as poultry. We work very closely with CDC to investigate and respond to cases of infection in humans, whether it's the H3N2 across to the States and the fairs and these issues, as well as the H7N9 virus in China. We also have ongoing roles in monitoring illness, supporting these investigations, and providing education. Our laboratories do a tremendous amount of testing in influenza. We probably have one of the most extensive surveillance systems in the world when it comes to influenza, especially in the poultry area. We've done 478,000 tests in 6 months. That's a lot of tests for influenza. We have approved vaccines that we approved by our Centers for Veterinary Biologics for Salmonella in poultry. We also have an approved vaccine for E. coli to hopefully reduce the shedding of E. coli. We do science-based policy. We report on the quality of U.S. milk, which probably a lot of people didn't realize that. We work with other agencies to determine critical information gaps that are related to food safety and security. And we support the judicious use of antimicrobials in livestock. But what are we going to do in the future? And we're already begun to do this. Veterinary Services several years ago beginning to look at our vision for the future. We called it VS 2015. Now we call it VS Vision and Science. Part of this is building a One Health capacity within the organization. Years ago, food safety was taken out of our domain. In fact, APHIS was the beginning of Salmonella Emeritus control in layer eggs. That program was moved to FSIS under a reorganization and then later moved to FDA. We were told to stay out of the food safety arena. Today, we're back in the food safety arena. We have a role to play in pre-harvest food safety. But it needs to be a role in a non-regulatory approach. Why? Because we have the trust and need to keep the trust of the industry we're primarily there to serve on the animal health side, and that is the food animal industry. So we need to be there in a voluntary, non-regulatory, non-threatening way, not in a regulatory manner. We need to be able to provide data and collect information and keep it confidential to be able to support the needs and the gaps that exist today for the benefit of the industry, but also for the benefit of public health. So we need to support the industry by identifying and addressing pre-harvest food safety issues and assist in outbreaks and analysis. And sometimes it gets a little dicey to be able to do this. But you take a regulatory agency, and now we're talking non-regulatory. And a lot of the things that we're going to be doing in our future are non-regulatory. We want to continue to support the overall federal One Health efforts in diagnostics and biologics, in stakeholder engagement, and in epi investigations. We at USDA are developing an antimicrobial resistance plan to be further engaged to assist in identifying the science and helping address the gaps that exist in this issue, and hopefully better inform FDA when they take regulatory action now or in the future on these issues. We need to continue to work with other agencies on new technologies to address zoonotic pathogens, help ID and respond to emerging and re-emerging diseases, as well as support state projects at the One Health level, and develop those templates and information sharing between public and animal health agencies and disease investigations. Now, I talked about a new model. Our traditional model of disease eradication and control is You build a program around it, you develop regulations around it, and it's funded by Congress. Or you have an introduction of a disease. You declare it as an emergency because it's a regulated disease. You get emergency funding and you address it. Now recently, you all have seen or heard of the porcine epidemic diarrhea, which is not a zoonotic disease, but I'm using that as an example. We've been working with the industry on that issue, but we're going to hopefully do a hogwash on that and look at trying to build a new model. So for example, diseases of economic significance or of public health significance, we need to be able to address those and have access to ready sources of funds like the CCC emergency funds to be able to immediately address those in a preventive way to prevent them becoming larger and having greater economic impact, having greater social impact on public health and other issues. And you got to do that in a non-emergency threatening way. If you do not, you will not get the information and support you need from the animal health side, from the producer side, to be able to effectively address this. And they have to be able to be compensated for losses if you're going to do this. Until you can decide, until you have the time necessary to be able to appropriately decide what actions are necessary in the future. These have to be quick actions, not sitting for months waiting to think about what you're going to do next. So we're very excited about the role we can play, the collaborative role in the future, and working with our federal partners. And we need to, with limited resources, prevent duplication and work together effectively. Thank you.
Thank you, Dr. Clifford. And we do want we want you to ask questions. We want to have a great discussion coming up after Dr. Thoen's talk on tuberculosis. So we look forward to that.
I'm Charlie Thoen. I work at Iowa State University at the College of Veterinary Medicine in AVES. I've been interested in tuberculosis for a long time. There's been a great deal of new information. What I'm going to try to do is give you a brief overview of some of the important things that I think are here and what we're going to have to deal with in the future. It's interesting that in spite of the fact that we've worked on tuberculosis for a long time, we still have some real problems in controlling and eliminating the disease. According to Dr. Reitman, TB kills more people than any other infectious disease today. And I think the next item is of significance. 1 in 3 people alive today harbor the tubercle bacillus. That's very, very high. TB kills more people today than at any time in history, in spite of the fact that we have anti-tuberculosis drugs that are effective in treating tuberculosis. It's important also to mention that we have a reemergence of tuberculosis. And why? Well, in part because of the immunocompromised host. They're not able to contain the infection, and as a result, we have more people that are contagious, and there's a greater spread of disease to susceptible hosts. Secondly, we have the problem of drug resistance. We have what's referred to as MDR, or multiple drug resistant strains of TB, that are resistant to 2 or more of the primary drugs that are used in treatment. And then what we're seeing now is a greater increase in XDR strains. These are extensively drug resistant strains of M. tuberculosis. They're resistant in most cases to all 3 of the drugs that are used for primary treatment. We also have a problem with compliance, getting people to continue on drug therapy once they start. And also, there's some evidence that drug users are more susceptible, which is probably an important issue in some areas. The tubercle bacillus was first discovered by Koch in 1882, I'm sorry. And it's interesting that although Pasteur had done a lot of work and isolated most of the pathogens, he failed to isolate the tubercle bacillus. While some people say that he was just too meticulous. He grew organisms, and if they didn't grow in 7 days, he discarded the plates. Well, Koch was a little different kind of person. He wasn't quite so careful. He went off on vacation one year and went to the sea to sit in the sun, and he came back about a month later, and his laboratory worker came in and said, "Look what I have on this plate." And they had a colony on there, and he stained it, and it was acid fast, and he had isolated the tubercle bacillus. It was really quite interesting, because when Koch attended this meeting that was presented, when Pasteur attended this meeting, he was quite impressed by the findings of Koch. Tuberculosis in humans, it's 99% M. tuberculosis. M. tuberculosis is also the major cause of tuberculosis in elephants and in non-human primates. Mycobacterium bovis is an important pathogen in humans, and specifically in certain areas. And I think that this one report that we have here is published by Dr. LeBeau at CDC. This is CDC now, it's on San Diego. You can see that 129 of the 1,991 cases of TB were M. bovis. And 53% of those cases were extrapulmonary. So a much higher percentage of extrapulmonary disease with M. bovis. And then we see that 23% were HIV, or probably immunocompromised. We had an outbreak of M. bovis in elk several years ago. And it's interesting that there were 394 tuberculin test positive individuals that were exposed at rendering plants where these animals were processed, and 81 of those people responded on tuberculin test. But there was only one culture positive case, and most of the workers that were in that particular facility had received BCG, and some of them didn't have a record of it, so it's hard to evaluate the findings in this particular case. Well, control of tuberculosis in humans, the tuberculin skin test. J. Arthur Meyer said it's the master key. And it still is in many countries around the globe. We have some new tests, and we can talk about that. They're really correlates of delayed hypersensitivity of the skin test, if you would. Using more purified antigens has improved specificity of the testing schemes. And then I think that we have to consider that how do we handle these cases once we find them? They like to isolate active pulmonary TB cases until treatment has shown that the individual is non-infectious. That means they're not releasing the organism into the environment. Contacts, usually a second TB is administered in 8 to 10 weeks after initial exposure. Many times people will not respond to the test if tested in just a few days following exposure. And vaccination with BCG is used widely around the globe in non-industrialized or developing nations. It's not that it protects against infection, but it delays the onset of the lesions in people. So it is used, and it's used quite widely. It's an inexpensive approach. There are several different strains of BCG, and I'd just like to comment on that. Many people think there's one strain of BCG. That's not true. There's many strains of BCG, and what's important about this is that they vary in virulence. And some of the more virulent strains induce better protection, but there's also the concern then that they may produce disease. So it's kind of a two-edged sword. Treatment, I've listed some of the antituberculosis drugs here, and what's important here is how long are they on treatment. And we don't know if we get a cure all this, but if we keep them on the proper duration for treatment, the success rate is much improved. Now in many countries, it's very difficult. When people get to feeling better, they say, you know, I'm okay, I don't need to take these drugs. So they're initiating a plan referred to as DOT, Direct Observed Therapy. Direct Observed Therapy. They come in and they make sure that they take their drugs for this extended period of time. So control of TB in animals, and I've simplified this a bit, but the delayed type hypersensitivity test, either the skin test or the in vitro correlates of delayed hypersensitivity are utilized. And when we have an outbreak, we try to isolate or quarantine the population so we don't have these animals spreading the disease to other animals that they might come in contact with that are free of tuberculosis. Another item that I think is extremely important from my work many years ago with USDA, and since then, is use of the proper disinfectant. The only disinfectant that's really efficacious in destroying the tubercle bacilli are the chrysalic compounds, or the substituted chrysalics. Of course, if you're going to use disinfectants, the most important part is to clean up the area. And if you don't clean it up, well, then the possibility of destroying the organisms is reduced. Treatment, we only use treatment in non-human primates and in elephants in most countries. This varies, though, from one country to another. And then there's a few endangered species. We don't like to use treatment because with treatment we have M. bovis, you can have bone lesions, and when you have bone lesions you can't attain suitable levels, blood levels, to kill the organisms in these bone lesions. So you have the problem of exacerbations of TB after following treatment for periodic intervals. BCG is not utilized in humans. There are a few countries where studies have been conducted, but by and large these studies have not been successful in controlling and eliminating tuberculosis. First of all, BCG, as I mentioned earlier, does not protect against infection, but it may, in some cases, reduce the development of lesions in individual animals. But the problem here is that you can have vaccination failures in these animals, and in a population you may have only one animal, but if it's contagious it'll stay in the population and continue to spread organisms to the other animals in the population. Could you turn that off for just a second? Okay, so the treatment. This shows a procedure that we use in elephants. And you'll notice that one elephant in the upper right-hand corner there is shedding a tear. You know, it doesn't like what's happening. One of my students is showing here administering the antibiotic, and when it does it, when an elephant refuses to take the antibiotics orally, well, they have to go to the other end of the animal. And the animal doesn't have much opportunity to object there. So you can get suitable blood levels here. What about the disease? This shows something about the occurrence of TB in humans in different countries around the globe. And I'll move these kind of fast. These slides were provided to me by Dr. LeVeaux at CDC. Here we see the presence of MDR isolates of TB. And what's important here is a widespread occurrence of these isolates. Now there's some areas that are white, but the problem there is they don't have any data on these areas. And this is of real concern to people involved in the control of disease. And this slide shows the occurrence of extensively drug-resistant TB in different countries around the globe. And again, you can see the organisms are being isolated widely in different countries. Estimated cost of treatment of XDR TB, $500,000 per individual. Why are we paying so much money? Well, we can't afford to have these organisms introduced into the population. So what's ahead? Many years ago, before the discovery of streptomycin and other anti-tuberculosis drugs, they placed people in sanatoriums. They isolated them so that they didn't have contact with people free of disease. And one of the procedures was to put these people out in the cold. And this happens to be at Saranac Lake, New York. Many of the people from New York City that had TB went up there for treatment. They put them out, leave them out in the cold all day. They'd heat large rocks in ovens, and they'd put these large rocks under the blankets, and they'd sit out there. And it's very interesting. that 1 out of 4 of the people that were admitted recovered sufficiently to go back and live in their home in New York City. So the immune system responded in protecting them. This was an individual isolation unit, if you would. It's called the Red Cottage. The important thing was built in 1984. This is just 2 years after the discovery of the tuberculosis. Well, I first met Dr. Steele in 1968. He was in Rochester to visit Dr. Carlson, my major professor. I was working on my PhD thesis at the time at the Mayo Clinic. And we had a good visit, but I was just a student, you know, at that time. But a few years later, I met Dr. Steele again at the World Congress in Boston, and he suggested to me that we ought to have a book on M. bovis infection in animals and humans. So this book was put together and was published in 1995. A second edition of the book was published in 2005. Dr. Steele didn't give me much time to think about getting a second edition off the ground, you know. 2 years after the first edition came out, he said, "Charlie, we got to have a second edition." If any of you worked with him, you know about that, I think. Well, then in 2009, I was at this meeting in Seattle, and it's time that I received the Gold Cane Award, and he approached me again and he said, "You know, we need to have a new book out." So we started work on the new book, and this is a cover from the new book that we have, and it's going to be published and will be on the, it's in press now and will be out in about 6 to 8 months, perhaps for sure by mid-2014. What's important about this, I wanted to say, is that the new book contains quite a bit of information on tuberculosis in humans, which we didn't have in the first and second edition, if you would. And that information was provided by Dr. LeBeau at CDC, Dr. Anderson at the International Union on Tuberculosis and Lung Disease in Paris. And it includes new information on epidemiology, molecular techniques for identification. So it's really a new book, if you would. And we received support from the U.S. Department of Agriculture, Animal Plant Health Inspection Service, financial support, if you would, veterinary services. Dr. Clifford, thank you. Appreciate that. Wouldn't have been possible without that. It's expensive to publish books and to get people to do things. I want to also say that Dr. Steele's involvement in this book was very, very important. He read each of the 34 chapters, and he offered constructive comments that were very helpful in editing, Thank you, Dr. Steele. I'd like to have a round of applause for Dr. Steele's involvement in these 3 books. 3 books published in 20 years, and 1 at the age of 100. Quite an achievement. Thank you. I'm starting to go over.
All right, folks, to set us up, Peter's going to come up front to set the stage for the discussion. I'm going to give you a rapid-fire summary. So here's a summary of what we've heard over the last 3 hours and 20 minutes. You know, we started off with the Jim Steele challenge. We heard several times the comments about the challenge he was given 70 years ago was, what are you veterinarians going to do now that the war is over? And I think Jim has stepped out to us now and said, so what are you veterinarians going to do now that the 20th century is over and we're more than a decade into the 21st? What are you going to do now? Karen set the stage nicely by saying the purpose of this session was to gather together leaders, or perhaps I should say gather together some of the personalities of veterinary public health and our colleagues to enunciate the compelling vision for tackling the grand challenges that we face now and growing in the future. So the program included some discussion of the past, the present, the challenges, and the opportunities. Peter talked about the waxing and waning of One Health. Lonnie talked about the 5th metamorphosis of veterinary medicine, from treating horses to livestock epidemics, to production agriculture, to the growth of production agriculture, to companion animal medicine, and now to One Health, Eco Health. We had a fascinating discussion of this bond between pediatrics and veterinary medicine and the breakthroughs in basic science that help precipitate. We talked about, and I appreciate very much Bill McCulloch talking about the veterinary role in mental and emotional health, the foundation of the Delta Society, and R.K. Anderson, who many of us knew well. You talked about successes, so I appreciate very much Linda Logan from reminding us that not to forget the successes. George Beran talked about this rabies eradication campaign in the Philippines and the really transdisciplinary team that engaged the community and was in a successful eradication campaign in a developing country that must, by very necessity and resource constraints, operate differently than the developed world in which most of us have most of our experience. We talked about, Linda referred to the rinderpest eradication. We talked about and she shared with us collaborations in education and training and regional research centers in Africa. There were several mentions, multiple mentions about successes. John emphasized from the APHIS looking at the TB and brucellosis successes, the progress in data collection and surveillance systems, the preparedness and response to the BSE incursion and the ongoing avian influenza surveillance as illustrations of the breadth, increasing breadth, if you will, of what we all grew up with traditional veterinary services as it reaches out. That really sets the stage for the present moving into the future and some of the many challenges. We can't rest on the laurels of our many successes because, in fact, those successes were at one point in time and the challenges are changing. Charlie Thoen just